So today I'm joining you from Frontier Nursing University. I'm going to talk about the many roles of certified nurse midwives and women's health nurse practitioners. Frontier Nursing University is located in Versailles, Kentucky. We're a remote university, so I'm joining you from Orlando, Florida. And it's not allowing me to advance my slide. There we go. I could do that at the bottom. So our department chair for midwifery and women's health is Dr. Eileen Thrower. She will be joining us shortly. And I am Dr. Noelle Jacobsen. I'm the interim clinical director for the Department of Midwifery and Women's Health. And like Dr. Thrower, I am a certified nurse midwife. Again, I welcome you today to talk about your future and potentially joining us as colleagues. So this is kind of a little pictograph of some of the things that we get to do as certified nurse midwives and women's health nurse practitioners. And if you look at some of these pictures and it sparks interest in you, then you're probably in the right place, because this is the type of care that we provide. So our goals today are to explore the roles, experiences, joys, and challenges of nurse midwifery and women's health nurse practitioner practice. And then we're going to talk about the path that nurses can take to advance practice nursing and what to expect when you get there. So you've probably heard the term APRN. It used to be ARNP, but the common terminology that's most accepted is APRN, Advanced Practice Registered Nurse. And that's kind of an umbrella term, and that actually includes any type of nurse practitioner, including women's health nurse practitioners. Other specialties include family nurse practitioners, psychiatric mental health nurse practitioners. We do have programs in those as well. You also see neonatal nurse practitioners, pediatric nurse practitioners, and geriatric nurse practitioners, adult nurse practitioners. There's many, many types of specialties. Today, we're going to focus on women's health nurse practitioners and also certified nurse midwives. Other APRNs include certified registered nurse anesthetists and clinical nurse specialists. So CNMs and WHMPs are APRNs who specialize in comprehensive healthcare for women throughout their lives from puberty to menopause and beyond. So many people, when they think of CNMs, oftentimes think of only that childbearing time in a person's life, but it's actually much broader scope of practice than that. Both CNMs and WHMPs assess, diagnose, and treat the healthcare needs of women, including health promotion, disease prevention, and health education. It's important to note that the practice scope of both is founded in inclusivity. So we do, in fact, care for all people, including regardless of their biological sex or gender identity or their sexual orientation. There are two main professional organizations for these two professionals. CNMs are within the American College of Nurse Midwives. That's a great place to start to learn more about becoming a CNM and getting engaged with that professional community. And you can go to midwife.org to learn more about that. Midwifery Week is coming up in October. And if you Google that, you'll see a lot of exciting events. Frontier is hosting an exciting webinar that's free to anyone who wants to attend in the fall. And WHMP's organization is NPWH, the Nurse Practitioners in Women's Health. And you can go to NWPH. I think that's backward, npwh.org. Just reading that, I realized those letters were transposed. I apologize for that confusion. So really, CNMs and WHMPs are the same, and that we are all primary healthcare providers to women throughout the lifespan. We perform physical exams. We have prescribing privileges. One of the tenets of our prescriptions are contraception. We order and evaluate and manage laboratory and diagnostic tests. We provide gynecological care, prenatal care, again, primary health care to women, health education and counseling to women of all ages.
Hi, Dr. Jacobsen. Can you hear me?
Hi. Yeah, Samantha.
I'm going to jump in. This is Eileen Thrower.
Oh, Dr. Thrower. Hi.
I am the department chair of Midwifery and Women's Health, so I just wanted to let y'all know I'm here, and we'll jump in and help Dr. Jacobsen with the presentation.
Great. Thanks for joining us, Dr. Thrower.
Thank you. So So let's talk just really briefly about the scope of practice that the differences between the scopes of practice for the two professions. Some of them are things that might be kind of obvious to you. For instance, obviously CNMs attend women in labor and birth and catch those babies. They also, one thing that we may think a little bit less about is actually even assume care for newborns up until 28 days of age. That's a role that we more commonly participate in at out-of-hospital birth settings like birth centers and home birth practices. But some places in hospitals, even midwives do take a responsibility for that kind of care, and certainly is within the scope of practice. One thing that CNMs don't do is assume the care of male patients or patients that identify as men. That is pretty much limited to partner treatment for sexually transmitted infections, and that's different for WHMPs who assume full responsibility for the reproductive care of men. In addition to that, I would add WHMPs tend to have a little bit more focus on primary care. So both midwives and WHMPs certainly are primary healthcare providers, but WHMPs have a little stronger focus in healthcare and a little stronger focus in complex gynecological care. So those are kind of some of the big changes or differences, in the scope of practice for the two specialties.
Another important difference to think about when you compare being a CNM versus being a WHMP is the work life. So as a CNM, of course, we take call because babies do not have calendars and do not care about holidays or weekends. And so as a midwife, you will be responsible for covering those sorts of atypical work hours. And midwives will work in birth centers, home birth practices, hospitals where, there's really an acute level of care in the hospital environment, and then outpatient in offices and clinics. WHMPs tend to work a more typical work week, so Monday through Friday, no weekends, no holidays, and tend to do the majority of their work outpatient in offices and clinics. Some may do some inpatient. I know WHMPs who do inpatient postpartum rounds, or they might do some inpatient high-risk antepartum patient management. But again, they're not going to be on the labor unit managing labor or doing births. And so they have more control over certainly their in-person presence on the unit. They may need to take call at night for the practice in order to take those emergency patient calls, but they don't typically have to leave home to go in and manage patients as much as a CNM would. So that's an important distinction there to think about your future life and what you're anticipating for your life to look like in the next 10, 20, 30 years.
So this slide is just kind of looking at the potential for employment over the next few years, and CNMs, CRNAs, and NPs are really in a good position, I think. If you're considering this as a career option moving forward, there is a lot of growth in these fields, a lot more than in some other areas than you might that we might look at. And so in terms of employment, I think that there's a lot of job security moving forward for both roles, actually, for nurse practitioners and nurse midwives.
Yeah. We're going to look at some WHMP statistics. WHMPs are sort of a small, tight-knit group. There's only about 10,000 nationwide, and then they only make up about 3% of U.S. nurse practitioners. Those WHMPs who work full-time, about 43% hold hospital privileges in that way that I was describing before. And NPs in all 50 states and District of Columbia hold prescriptive privileges, and that includes DEA, so prescribing controlled substances.
So here's some information that I think is important to know when you are considering job options or career options. This slide demonstrates some statistics from a couple of years ago, which are the most recent that are available, but the median salary for a full-time nurse practitioner is seen here, as you'll see, about $110,000 per year salary, and nearly 60% of nurse practitioners see 3 or more patients per hour. And I think that's an important thing to think about for a minute from a couple of standpoints. One, it's interesting to think about the impact that we are having on the population as advanced practice nurses as we're seeing that kind of patient volume. I also think it's a good thing to think about as you're going in, as you're considering a field that you might be interested in. That's a pretty busy schedule when you're seeing 3 or more patients an hour, and then also having to do documentation on them. So while the WHNP does not, as Dr. Jacobsen pointed out, is mostly working in the office Monday through Friday, doing much less nighttime work and weekend call, those office hours can be challenging and full of adventure and a lot of good, a lot of opportunities to interact with patients, but also it is sort of a busy work day. The average length of time, there's practitioners that are out there in the world functioning right now. The average length of time is that they've been in practice for about 11 years, which I think is just kind of another interesting thing. If the average age of the nurse practitioner is 49 years, you can imagine over the course of the next 15 years how many more NPs we're going to need to take the place of folks as they're moving towards retirement. So that's a little bit of data there.
So we look at where are WHMPs practicing. 84% are doing direct patient care, so going in the office every day, taking care of a full patient schedule. 4% are in academia, so that's what Dr. Thurr and I are doing. We're investing in educating the next generation of CNMs and WHMPs. 3% are in management and administration. 1% are in research. 0.4% are doing direct patient care and management, 0.3% in health policy and advocacy, and 7% are retired, not employed, looking for a WHMP job and working, but not in a WHMP role. Sometimes, we all have our lives and things wax and wane, and you still have an RN. And sometimes when you have busy things happen in your life, I do see NPs sometimes go back and do an RN role just because that 3 12-hour shifts are really attractive when you have a busy life. So nobody's taking your RN away from you, and you have a lot of flexibility, and hopefully something on this list piques your interest for how you'd like to be spending your time in your career.
All right, so let's contrast that a little bit on the CNM side. So nurse midwives, their salary will vary a little bit more based on where their job is physically located. So you can see the range there varying from the lower 100s to closer to $150,000 depending on where the nurse midwife is working. I would say the median income is somewhere right there in the middle of this range, most likely. Again, these aren't necessarily starting salaries, but this is kind of more of a median salary for all midwives across the industry. And again, reflects the same kind of, whether you're working strictly outpatient, whether you're working a strictly inpatient hospital, which midwives will do at times as working as a laborist or a hospital in a labor and delivery unit. The nice thing there is it reflects more of a role like an RN where you may just be doing three 12-hour shifts or something more of that nature. Some of these are just, some midwives work strictly in an outpatient physicians-based office. And then again, like Dr. Jacobsen and I, some of us are teaching. Mm-hmm.
So when we think about the midwifery model of care, it is a culture in and of itself. And I think that that's an important drive for many of us who became midwives or like you are interested in becoming midwives or WHMPs. We are really proud of our statistics in our profession. So 33% lower risk of neonatal mortality when people receive care from midwives, 31% lower risk of low birth weight babies, 19% lower infant mortality. We use less medical interventions, lower C-section rates. We're very focused on education, health promotion, risk reduction. We care for our patients as whole people, so very holistic care, looking at the dyad between the mother and the baby, and our patients report really high levels of patient satisfaction. So if you have a drive to improve outcomes and to build relationships in your community, this is probably a really good fit for you.
So one thing that we really are aware of in this country is that there's a lot of confusion around midwives, and that's largely due to the fact that there are lots of different pathways to becoming a midwife, and even a lot of folks within healthcare don't really understand the distinction between all the different types of midwives. So we wanted to go over that with you really quickly so you maybe have a better understanding of that. What we've been talking about today is the certified nurse midwife. So those midwives are first RNs. They have a BSN as an undergraduate, and then they go on to an accredited midwifery education program that is certified by the Accreditation Commission for Midwifery Education, or ACME. The CNMs all sit for boards that are given by the American Midwifery Certification Board. So similarly, so that's a certified nurse midwife, and that's the most commonly prepared midwife in this country. There are approximately 12,000 certified nurse midwives in the country. A similar type of midwife is the certified midwife, and the difference there is that they don't become RNs first. So they don't have a BSN, they've never sat for the NCLEX, but they go straight into a midwifery education program that is also accredited by ACME. And they've also taken boards that are given by AMCB, or the American Midwifery Certification Board. So the level of preparation and the scope of practice are exactly the same. An important thing to know, though, about the CM is that the practice of CM is only allowed in a small number of states at this point. Dr. Jacobsen, do you remember? I think it's less than 10.
It's 6.
Yeah,
I think at least 6 is less.
6 or 8, maybe, I think, that states that allow the practice of certified midwives, certified nurse midwives, practice in all 50 states. So those are different from a certified professional midwife, or CPM. Our CPM peers are typically more apprentice trained, or perhaps have gone to a midwifery education school that is accredited by a different board. NARM is one of them, or the Midwifery Education Accreditation Council. But those CPMs sit for the NARM boards, which is the North American Registry of Midwives. They are not nurses. They practice in out-of-hospital settings almost exclusively. So CPMs are commonly found in home birth practices or birth centers. But they have a different education level and a different certification level than CNMs and CMs. However, they are certified they do sit for a certification exam, and they do have certification. Then the final group of midwives, which is a much smaller number, I think in the country there are, if I'm not mistaken, around 3,000 CPMs. And then there's a smaller number of what we refer to often as traditional midwives or community-based midwives, and they're exclusively apprentice trained and are not certified by any national certification body. So those are kind of the different paths to midwifery, and this is part of what leads to some of the confusion in our country around what is a midwife. But I guess my take-home message from this slide is that the vast majority of midwives in this country are CNMs.
So here you go, Dr. Thrower. You were just taking a quiz that you didn't know was answered on the next, trying to guess how many people there were. So there are over 12,000 CNMs in the US, 119 certified midwives, and just under 2,500 certified professional midwives. So in the state of Florida, where I am, CNMs are recognized and practiced. And CMs are not, CPMs are not. Interestingly, Florida as a state has its own thing called licensed midwives, or LMs, that are recognized. So it is pretty complex and confusing, and important to know what's in your state. In 2019, CMs and CMs attended about 369,000 births in the US. 92% of all midwife attended births are CNMs and CNMs. So really CNMs and CMs are the lion's share. And really, when you look at the numbers, CNMs have the lion's share of midwifery care in the US and are doing about 10% of total US births. I know in Florida, it's about 11 to 12% of Florida births are done by CNMs here.
All right, so let's talk about the paths that you can take to becoming a certified nurse midwife or a women's health nurse practitioner. So for either of those roles, CNM or WHMP, it's required to be an RN first, and also a bachelor's degree is required. It is not always necessary that you have a BSN, but a bachelor's degree is required because the CNM and the WHMP, the basic entry into practice for either of those roles is the master's level, so it does require having a bachelor's first. Many programs offer a pathway to maybe an accelerated pathway through the RN program or even the BSN program. Then there are other, as I mentioned, there's a few programs in the country for midwives that don't require you to be a nurse first, but again, that's a much smaller number of people are doing that. So CNM and WHMPs and typically are going to be RNs, and they're going to have a bachelor's degree in something. Most commonly a BSN, but that's not always necessary.
So you're sort of at this precipice now. I'm thinking most of you as members of AWHONN are doulas or RNs. And so you're wondering, you know, where do I want to go in my future? And so as educators, of course, we believe in education, and we very much are here to encourage you, if you have the thought of becoming a CNM or WHMP, to go for it, because we all know that as people, learning never ends. And you just are only going to gain and grow and feel better about yourself and hopefully find a career that's really the perfect fit for you.
So we all know that this is, on the top, this is kind of the plan that we want to have, and this is where we really are hoping that we go. And then on the bottom is more what it looks like. And I know that there's really not one of us on this call or watching this later at a recording, or even in this country or on the planet, that hasn't more experienced the bottom picture here. There's a lot of we've been through a lot of challenges in the last couple of years as a human race. So I would really echo what Dr. Jacobsen said. I think that both the WHMP role and the certified nurse mid role both are amazing job opportunities. And if you are a nurse that's kind of thinking about one or the other, we want to acknowledge that for many of you, this may be something you've been thinking about for a long time, maybe for years and years or decades. For others of you, you might be newer in the field of nursing, and you might just now beginning to be thinking about it. But please know that as educators that teach both CNMs and WHMPs, we know that sometimes your path just takes as long to arrive at that final destination as it takes. And I would also encourage you to really keep, if it's something that you're dreaming about, reach out. Dr. Jacobsen and I would love to talk to you more about it. And I know there's lots of other universities in the country that would also. So whatever's in your neighborhood or seems convenient that you might think could work for you.
Yeah. And when you hit those pits and valleys or you're losing motivation, I encourage you to connect with those in the midwifery or nurse practitioner community. So, I've gotten letters from people who are like, hey, I'm just going to go to lunch and talk about what you do. And sometimes that can really help, or go to an ACNM or NPWH meeting and just sort of meet some of your people. And I think that when you start meeting the people who would be your future colleagues, you start to realize how this is your tribe of people. And I think that that can be very motivating. So don't be shy. And everybody is busy, but everybody also just likes to chat and help other people. So don't be afraid of that. And so this is why we always say, surround yourself with those on the same mission as you. So find those who share in your dreams and your goals and your desires and your service metrics to give back to your community. And I think you'll find a lot of motivation from making those connections.
So Dr. Jacobsen and I both are teaching at Frontier Nursing University, and this is the mission statement at Frontier Nursing University, and it's one that really resonates with me because our emphasis at Frontier really is on educating and preparing new midwives and new nurse practitioners. That's really all about what we do. But what I love about it, our work at Frontier, but in a broader sense, really across the country, I think I can speak really for our peers that have gone through other education programs. I really think we all have just what Dr. Jacobsen was referring to with that like-mindedness, and really have pursued our careers as midwives and nurse practitioners because we have this passion for providing access to care for people, particularly people that are in rural and underserved areas, which at this point in time, there's almost no state, there's really basically no state in the country that doesn't have significant areas of its geographical regions that would either be rural or underserved. We also are really passionate in the field about creating diversity within our profession. We know that concordant care, where the person providing the care looks and has the same lived experience as those being cared for, really results in better outcomes. So I think that this is a real draw for many of us into the profession, that we know that we really want to provide that kind of patient-centered care where patients are really involved in shared decision-making and really being provided by people that have had very similar lived experiences as our population served. And we know that's really important as we move forward in healthcare to achieve the kind of outcomes that we want to have moving forward.
Yeah. So a lot of us have this thought all the time, like, I can't do it, it's too much, it's too hard, I don't have the time, I don't, etc. And so we're just asking you to get out your scissors and just realize that you can do it. Many people have done it before you, and people who have harder circumstances than you have done it. And so just, again, find that motivation and find the support and make a connection. Find a mentor to get you to your goal, because I've never met anybody who said to me, I regret becoming a midwife, I regret becoming a WHMP. It's just not real. You know, if this is your drive and this is what you want to be doing, you're going to end up in a place that's going to really help you feel more whole.
And I would love to add to that before we go to the questions.
Yeah.
I think it's almost across the board that when you go into a new education program, especially when you've been a nurse, if you've been a nurse for a long time, you've become an expert in the field. And so going back and starting over feels really uncomfortable. And it's really common to go into a new education program to pursue a new field or a new role in healthcare and feel like an imposter. It's really common. I think that I speak for myself. I see Dr. Jacobsen shaking her head, like getting into the program thinking, wow, I'm really not sure if I should be here, because it's hard for me to envision myself in this advanced role. But I really want to acknowledge that it's really the norm.
Yeah.
It's extremely common, but I would say it's really the exception if you don't feel that way. So I really just wanted to add that to say, please know that if you have become an RN and practiced as an RN, then you are well on your way to demonstrating that you have what it takes to be an advanced practice nurse.
Yeah. So our students, Frontier students, come to campus in Kentucky to sort of launch their educational experience. And last time I was there, I was with a group of 10 students studying to become WHMPs, when I asked them about their journey, I think 8 out of 10 of them expressed complete shock when they got their acceptance letters. And I was just like, no, you're here because you belong here, and you earned that. And so you have a seat at the table. And they just were still in awe that Frontier had accepted that. And it was really very humbling to realize what a major step that is for so many people. And so again, we're just here to encourage you and let you know that we know you can do it. So we just want to sort of open up the floor and have you ask questions, anything specific, anything we went over, anything we haven't mentioned, whatever comes to mind, we want to chat with you.
Hi, I have a question. I recently graduated with my BSN, and I went back to school to get my BSN specifically to become a nurse midwife. Mm-hmm. So I know that that's where I want to go, and I have a job starting in a few months on a postpartum floor, but I was wondering what you would recommend as far as like how much experience is kind of ideal before going back to school. Should I try to also work on a labor and delivery floor? What do you recommend to be kind of well-rounded to be prepared for graduate school?
Well, Jamie, thank you for that question. I think that is one of the most common questions that we get. So thanks for bringing that up. I'm going to give you my answer, then I'm going to ask Dr. Jacobsen to also weigh in. Yeah. I first want to say that labor and delivery RN experience is absolutely not a requirement in any way to become a midwife. It is 2 separate roles, and there is no requirement at Frontier, and I don't believe that very many universities that anymore are requiring you to have labor and delivery experience. So I think that whatever experience you bring with you to a midwifery education program, you're going to benefit from. So if you have postpartum experience, that's great. But also if you have worked as a nurse in ICU or med-surg, there's always going to be relevant things that you're bring to the role with you, no matter what field you've been in. Once you get into a midwifery education program, the learning curve is a little different based on what your experience has been. So somebody that has a lot of years of labor and delivery experience as a nurse, it's going to look different than if you have none. It may be easier, and it may be easier for that person that has a lot of labor delivery experience, but I'm not really convinced that it is, because sometimes there's a lot of work in unlearning some bad habits that people have learned. There's a lot. It can make the role transition sometimes more challenging. So I don't know that it's necessarily better or worse. I just think it's a different path. I will also tell you from my experience, I was a nurse for 3 years before I became a midwife. I worked postpartum for a while. I worked NICU, and then I also worked labor and delivery for 1 year. So I had that covered to at least for a small point of time, but I'll tell you what I never did one day in my entire life was work as a med-surg nurse or anywhere outside of women's health. And I can tell you that in some ways that offered me challenges, because I didn't have that sort of foundation that many people would come to if they'd had any of those other types of nursing experience. So whatever you bring with you offers its advantages, but no one's expected to have all the experience of every kind of nursing. That's just not possible. So Jamie, I think you're going to be great. You're going to be fine. You're an RN. You're going to have some postpartum experience, and I think you'll be well on your way. But Dr. Jacobsen, I think, has a little different experience than me, so I'd love for her to address it from her standpoint too.
Yeah. Hi, Jamie. So nice to meet you. So I did not have labor and delivery experience. I had 3 years of med-surg. I only went to nursing school to become a midwife. I didn't have a BSN. I had a bachelor's in biology. So again, sort of, that second picture of the path of the pits and valleys was more of mine. I will tell you that, one of the things you want to look at when you're looking at programs is what their requirements are for admission. So some programs like Frontier requires a year of nursing experience or a letter describing your experience in some way that's applicable to graduate level work. So that's one thing you just kind of want to pay attention to when you're comparing programs. Secondly, I think postpartum is a great experience for you. You're going to learn a lot and you're going to bring that foundation with you. The thing with labor and delivery experience is that there are some very basic skills you earn by becoming a labor and delivery nurse that you can get as a student nurse midwife, but it's just going to it's going to be a steeper learning curve. So, for example, I remember doing clinical and I could not for the life of me find a cervix to determine how dilated somebody was. And I still remember she's like, what do you mean? You just go over there and there's a hole and you just put your in. Like, I couldn't do it. Like, I don't know. I struggled with it a lot. And, one of the things you want to consider is that when you are in your clinical portion, you need to find a preceptor who is willing to invest that little extra foundational time with you to build that bridge in the skill portion of what you need to learn. And so I will be honest with you in that I know there are preceptors who tell me my practice is too busy. I cannot take somebody without labor and delivery experience. I don't have the time. And that's okay, but it can be limiting. It upsets me as an educator and as someone who became a midwife for that labor and delivery experience that there's that bias, but I just think it's fair for you to know that that is a true bias that exists. And so you just may find some people who will not want to precept you without that experience. It's just reality that none of us can change because no preceptors are forced to precept. They're all volunteers, and so they can kind of pick and choose. That being said, I recently met with someone who hadn't precepted in years and then met with me and told me exactly what they wanted in a student. And she had this long list about someone who's very motivated, somebody who's done very well in school, et cetera, et cetera. And then I was like, okay, so you also, I made an assumption, you also want labor and delivery experience. She's like, no, I can take somebody that labor and delivery experience. I just need somebody who's motivated and committed to learning. So again, it's just so interesting how individual it is. So labor and delivery experience may prove to be a stepping stone for you for some practices to precept you. Then again, I know labor and delivery nurses who have been doing it and they come in to become a student nurse midwife and they walk in the room and they're already thinking like a nurse. They're like watching the Pitocin and they're looking at the IV and I'm like, so one of the things I do with labor and delivery experienced students is when you walk in the room, what are you doing? Because the first thing you want to do as the midwife is you want to look at the whole room, right? You're sort of getting that broader view because you're managing the care. And it's a very different lens through which to perceive or look at perceive the patient and the baby and the family than when you're a nurse and you're much more focused in a narrow sense. So it can, again, like Dr. Thrower said, we just sort of are breaking down some of those walls and retraining you to think like a provider. So risks and benefits of both, whatever you choose, you will end up feet down on the ground and planted with CNM after your name.
Thank you so much. I really appreciate it.
Yeah, you're welcome. Thank you for joining us today. Anyone have any other questions about midwifery, women's health, nurse practitioner, the career, the path to getting there? We're open to any and all inquiries.
Hi, my name's Sam. I have a question. I'm also a new graduate from my BSN. And I do really want to go into midwifery, but I've also been looking at the dual track of women's health nurse practitioning as well, of doing those as both kind of to make myself more marketable later on. Do you guys as Frontier offer that as a track course, and do other schools as well?
Sam, that's a great question. And we have a lot of students, again, asking that same question. So Frontier, it's not a dual program, but once you've completed our midwifery program, you can finish your WHMP in a relatively brief length of time, typically 6 months or less, I would say. There are other universities, there are midwifery education programs that offer a dual degree that would, at the end, you end up with the CNM and the WHMP. At Frontier, you just do one and then the other. But for us, at least at Frontier, if you do your midwifery first and then complete the women's health, it's much faster than if you were to do your women's health first and add the midwifery. It would take an additional 12 to 18 months versus 3 to 6, basically.
Okay.
So yes, and depending on the state that you live in, I think there would be a lot of advantages of doing that. We also have a lot of students that complete our midwifery education program and then come back and add the FNP, the family nurse practitioner, or the psych mental health nurse practitioner as a postgraduate certificate, which takes about an extra year. But I will tell you again, depending on where you live and what the needs are in your community, the CNM F&P can be an amazing combination, particularly if you're in a rural area where there just are very few healthcare providers at all. It really allows you to be prepared to care for the entire family in a way that just being a midwife doesn't. And then, of course, we know the mental health crisis that is really widespread in our country and really even more commonly experienced by people in that perinatal time of their lives. So because of that, a lot of midwives are adding the psych mental health program. What we know is that as midwives and as nurse practitioners, WHNPs, we do a lot of mental health. Nobody comes into, well, very few of us come into the role because they want to do mental health. If you wanted to do mental health specifically, you'd probably become a psych mental health nurse practitioner, but it's a big part of the role. And so it's, at Frontier, I will say that all of our APRNs have one course that's focused on mental health. But then we also have other specialties that come back and add the psych mental health. Not that I know that's not our purpose here today to talk about those other roles, but it's not uncommon for nurse practitioners to add another specialty. It just gives you more ability to take care of the people in your communities, is what we find.
Yeah,
Okay.
Those are great questions, Sam. Thank you.
Yeah. And Sam, I just want to also reiterate what Dr. Furr said is it's really important when you think about your role in knowing your state and what your state requires. And this is a moving target, right? Legislation is always being passed. It can be hard to kind of decode that, but there are some states that when I went to school, and so we're going back 20 years, but where there was someone I went to school with who did both, because she was saying that if she were only doing outpatient and not doing the inpatient, she needed the WHMP in order to do that, because as a CNM, she couldn't do that. Whereas I'm in Florida and you could be a CNM and you could do all the things that WHMP can do. So there's also insurance considerations, right? Because midwives are involved in labor and birth, our insurance premiums tend to be higher.
Yes.
Versus as an NP in the office only in less acute care, those tend to be lower. So there could be benefits and risks to either in that one realm as well. And then there's also the independence practice piece. Like in Florida right now, we're fighting legislatively because we got autonomous practice for NPs to be able to practice without a physician supervision, and yet we call it the glitch bill because there is a stipulation that if you're a midwife in doing birth, you do have to have the oversight. So we're trying to remove that now. So it's really interesting sort of how all of that fits together. So I think it's important to get to know your state, and you can go that through the ANA, the American Nurses Association, is a great place to learn about that. And specifically for midwifery, ACNM is a great place to learn about legislation in your state.
Excellent. Thank you so much.
Yeah, you're welcome. Thank you again for joining us.
All right. Any other questions?
Hi, my name is Elisa. I've been having some audio issues. Can you hear me okay?
Yeah, we
Yes.
can.
Perfect. Thank you so much. I'm actually in the process of my application for Frontier. I had a question more on the clinical aspect of the program. Do you find that past students have used like one practice to get their clinical time? Have they jumped practices? Is there a need to use more than one practice for CNM?
Yeah, Elisa, I'm going to go ahead and answer your question as the interim clinical director. So again, it's very individual. So if you find a midwife preceptor who does full scope, so they do both the outpatient piece in the office and they do births in a hospital, then you probably going to get everything you need with that single practice. Our program stipulates how many visit types you have to do for each different subcategories. For example, you need to do 15 peri or postmenopausal visits. So those are the questions you should be asking potential preceptors, like, hey, do you care for peri postmenopausal women? Many midwives, although that's within their scope of practice, they may not actually do that in their actual practice, because as the providers who provide birth care, they probably have schedules that are very heavy with prenatal and postpartum patients, because those patients really want to build those relationships. And so you may then want to add on an FNP or WHNP who does a little bit more GYN, complex GYN. So it's very individualized. Some students, I've seen students have multiple sites. If you want to do a birth center, for example, that's great experience, but we do require at least 8 hospital births. So that's to get a higher acuity level of experience. So yeah, so once you are accepted and looking at sites, we have a lot of support for that. We have clinical advisors to help meet with you, and then you have a regional clinical faculty. And you probably have about a year or so to figure that out while you're doing your didactic courses. Our program is set up so that you do all of your coursework, your foundational coursework first, and then you transition from doing all classwork to doing all clinical. Other programs have, when you're taking your antepartum course, you do antepartum clinical. Ours is separated. So it gives you some time to kind of find your niche and find your preceptors to get everything approved. Dr. Thoreau, did you have anything to add to that?
No, I don't think so. I think you covered it.
Thanks.
Thank you so much. That's very helpful information.
Yeah, happy to help. And ACNM, if any of you are in Florida or come to Orlando to Disney, will be in Florida next year. The first week of May, I think it is our annual meeting for ACNM, and they have discounts for students. And it's a great way to meet preceptors nationwide. And then the NPWH for Women's Health NPs is meeting in September. They have a national meeting there. So there are some great opportunities coming up to network with nationwide providers, which is pretty exciting to get to know who's who, where. Any other questions anybody has? We're open to anything, how general or how specific it is to you. We are really just here to help.
Hi, this is Elizabeth. I have a question about students in your program, specifically the CNM program. When you're going through the didactic portion first, what percentage of work, like, are people working full-time while doing the didactic work? Are they doing part-time? Like, what is the right balance that you have found with students managing working and going back to school?
So Elizabeth, that is another really, really excellent question. Thanks so much for bringing that up. At Frontier, I would say the vast majority of our students are working. I mean, almost all of our students are working during school. Mm-hmm. We may have there's a very, very few that may not work, but that's very, very rare. And I would say the majority of our students are working full time, honestly.
Okay.
We at Frontier remember at the graduate level, to be full time, it's really only 5 credit hours a term for us. So it's less than at the undergraduate level by a long shot. And we really encourage, so the quick answer is almost everybody works full time at Frontier, all of our students. However, having said that, we really do recommend that you try to limit, if you're working full-time, we try to ask you to just take 2 courses at the time. I think it becomes a little unrealistic if you're working full-time to do more than 2 courses a term, which makes the program last about 27 to 30 months, something like that. So just a little over 2 years. But we've just seen that the key to success is to have the time that you need to devote to your studies. And so folks that aren't successful, it's almost always because they just have too many other obligations in their life and then trying to take too many courses. So what we advise is we know the reality is that most people have to work because we have to pay our bills, right? And we want you to have a place to live and electricity and all those things. And it's very, very manageable, but it does require carving out that time, making a plan. And that typically is that you're only going to take 2 courses at the time and just go a little bit slower. It can be done faster, but again, that's really most likely to work for folks that don't have to work full time, at least. If you can cut back, that helps. Now,
Okay.
there are some times in the clinical part of it towards the very end that I think it's almost impossible to get through and still work those 312 a week. And so what a lot of students do is save up some PTO time so that they can take a little bit of time out, time away during those clinical hours. Particularly at the end, we have an integration type experience that requires about 30 hours a week that you're working clinically. So you can imagine it would be hard to do that plus 36 hours of work that
Right.
you're paid to do.
Now, is there a way, like if you started the program full-time and then you realize, oh, I need to back down, is the program flexible enough to kind of
Yes.
navigate that?
Yes, at Frontier, we are 100% about flexibility, and we want you to be able to make it work for you. So we have, yes, almost all students come in thinking they're going to go fast, and then they end up go slow, or they want to take it slow and end up going faster. Almost everybody changes. But the other thing is, you know, you may have one term, like for instance, maybe over the summer you think I've been full time, but now my kids are going to be home from school, so I need to cut back in the summer. That's great. So you maybe cut down a little bit and then pick back up in the fall. So yes, it's very flexible, and our advisors are experts at working with you to try to help navigate that. And we want you to be successful. We want every single person that enters our program to become certified as a nurse midwife or a nurse practitioner, whichever their track is. And so we're all about trying to figure out, to work with you to see how we can make it work for you and with your life and the responsibilities that you have to balance along with school.
Okay. Second question is partially answered about the clinical portion and finding preceptors for that portion. And I know Frontier helps with guidance. Is it because you have contacts of people who've taken students in the past? Or I guess that's a concern I have, because it's an unknown until you start that reaching out that you're in a program, and will you take me as a student?
Yeah, I'm happy to talk to you about that some. So we have a list of all preceptors and clinical sites that have had students in the past or currently have students. And we keep those on what's called a community map that all of our students have access to, and it has their contact information, etc. So students can look there. A lot of it is just getting creative about reaching out. So, you know, if you just send an email to somebody, it's just easy to delete and ignore it, you know. So our clinical advisors are really great about giving you some really keen networking strategies. A lot of our students make like a quick video, because you see somebody all excited and happy and, you know, and get that video, it's much more personable. A lot of students go to the office with like baked goods to, you know, a little sugar bribery can work, and it's harder to say no to somebody's face. So we have a lot of tricks up our sleeve, you know. And so our regional clinical faculty, so the faculty that are with you in clinical, are actually strategically located nationwide in pockets of communities and have relationships. So once in a while, there's a student who just has hit brick walls or hasn't found a way. And so we can lean in, and like, I could call a friend and be like, hey, I have this student, and, you know, and help out. And, you know, although we think it's much better for you to find your preceptor because it's your path, and we want you to be able to make a relationship and start building and getting to know the midwives in your community, we also have relationships to lean into when things are getting close. You know, if you're a year out, I'm not going to make that phone call. But if you're starting clinical in like a month or two and you're like, I don't have somebody, you know, then we're like, all right, like I can call and I can beg for you, and, you know, and see what we can get done. And yeah, so there's a lot there. With regards to working, it's important to remember in clinical that because you weren't doing any coursework when you're in clinical, most preceptors are going to expect you to follow their schedule. So that's the piece that you don't have control over anymore. And we all know you don't have control over when the babies are coming, right? So I've had students who are like, well, I'm working during the week and I'm on every weekend and I'm not getting any births. I'm like, yeah, because the babies don't care. Or your practice does a lot of inductions on Mondays and you're working your end job on Monday and you're missing those births. So it does require a little bit more flexibility in work when you're in clinical, just in order to make sure you're meeting your minimum hours and getting all your visit types. Office is a little bit easier, because people are scheduled. You can be like, oh, there are 5 postpartums on Thursday. I want to do Thursday and get some postpartums done. Yeah, so that's just sort of the reality of practice as a midwife. It can be harder to work when you're clinical, although honestly, most students do work, but I would say a lot of them are cutting back to that 24 hours a week during that time. But some are still doing 36 and just, plowing through.
Okay, that's good to know.
Yeah, it takes a lot of stamina. Yeah.
All right, thank you so much.
Yeah, you guys have great questions. Anything else you guys are percolating about, wondering?
We really appreciate you taking your time to come out and spend some time with us today. You're welcome to reach out to us after this is over. And we didn't think to put our...
No, but you can go to the frontier.edu website and there's more information there. And
you can probably find on there a way to reach out to me, but I'll tell you my email address is eileen.thrower@frontier.edu. So thank you.
Here's mine.
And those are, Dr. Jacobsen has put those in the chat box. So reach out to us and we would love to hear from you. And I'm excited about the opportunities that you are considering for your future.
Yeah. Yeah. Thank you, everyone. You can do it. That's all you need to remember is if this is what you want to do, it's got to find a way and do it. Ask questions, lean in. It's your future. Make it happen. We need you. We need more midwives. We need more WHMPs. The world will be a better place with you in it.
Yep, absolutely. All right. Thank you all.
Okay. Bye, everyone.
Bye.